go ahead for pregnancy loss. It has to be prevented. And that's why evaluation of pregnancy, we are not waiting for 3 loss, but sometimes needed to earlier intervention. When? If the woman is more than 35, we cannot wait for next pregnancy loss. And couple who had a difficulty to conceive, at that time we are not waiting for 3 loss. And when fetal heart activity has been identified prior to pregnancy loss, at that time we can calculate that the pregnancy loss is not a genetic one. It has to be a cause for that, because pregnancy is losing by showing a fetal heart rate. For this reason, what to know? My mind has to be increased, because when I does not know, I cannot see. That's why the mind has to be improved. What are the type of recurrent pregnancy loss? There are several type of recurrent pregnancy loss has been classified for the long ago: primary, secondary, and tertiary. But among them, primary is more common. What is the incidence of pregnancy loss? But 50% of all conceptions of our fail are mostly unrecognized. That's why SR guideline says the pregnancy has to be confirmed before we say the pregnancy is lost. How it can be said? By doing beta HCG. But lost is, most of the pregnancies are lost before implantation. Among them, we can say that 10 to 20% pregnant women have a sporadic pregnancy loss, not a recurrent. And 2% among the whole population, 2% consecutive pregnancy loss is in two consecutive spontaneous abortion in 2%, and 3 miscarriage in only 0.4 to 1% of cases. But incidence is not much bigger, but problem is bigger. What is the etiology of this recurrent pregnancy loss? Among them, 50% cases are not, cause is not known, but it is important, the cause is not known. And rest is uterine and anatomical abnormality, genetic abnormality. Autoimmune is occupy the 20% abnormalities. Infection and endometriosis is less, and endocrine abnormality is also occupy a big portion. It is 70 to 20% cases. How to investigate? Because after knowing the cause, then I treat the patient for successful pregnancy. And how to investigate? Investigation first, who is treatable and detected nicely, and this has to be done first, not to do a blind screening. No cause is found is important, because it is a prognostic value for future pregnancy. How? No cause is found. We can say the couple that you have a no cause, and this has a reassurance for prevention of subsequent pregnancy loss. It relieves the stress. Among the causes, one of the important cause has to be remembered. This is the age of the patient. Both husbands and wife. Not only maternal age. Advanced maternal age has a lot of complications and pregnancy loss. And gradual increase of age, pregnancy loss is more. It is started from 35. And paternal age is also important. It is not less. Why maternal age is important? It is important for oocyte quality. If oocyte quality is not good, pregnancy is not good, and then ended into a miscarriage. Maternal age causes chromosomal abnormality and also paternal age. And next, you have to sort out the reproductive history. How the pregnancy is lost. What is this chemical pregnancy, early pregnancy loss, or second trimester loss, or stillbirth? All are important. Because gestational age, why it is important? Gestational age, if it is early pregnancy loss, 60 to 70% genetic. If it is 8 to 10 weeks, it is important because antiphospholipid antibody is an important cause for 8 to 10 weeks pregnancy loss. And more than 10 weeks and mid trimester, usually anatomical causes of pregnancy loss. That's why repeated pregnancy loss, it is seen that it is occurring same gestational age. Same gestation, 4 months, or 8 weeks or 8 weeks. And next is important is lifestyle. Lifestyle among them is obesity is important, both for men and for women. Reduction of weight is important. So it is good to lose the weight in a structure problem weight loss. Dr. Pai said how to reduce the weight. And environmental factors. What is the structural and anatomical abnormalities of uterus which causes pregnancy loss? One is congenital malformation, septated uterus, unicornuate, bicornuate uterus, intrauterine adhesions, and intrauterine lesions like fibroid and polyp. Last of all, but is important, is cervical illness. How uterine abnormality causes pregnancy loss? By decreasing vascularity, inflammation of endometrium, and also reduce the sensitivity of steroid hormone, which are working for improving the placentation. And there is an association. What is the role of uterine abnormality causing pregnancy loss? Mullerian abnormalities causing second trimester pregnancy loss. But septated uterus, it is also a type of Mullerian abnormality which causes mainly the first trimester pregnancy loss, and it is a higher rate. Correction of Mullerian abnormality. Whether septated uterus, after correction after removing the septum reduces the miscarriage rate. But what the correction of other abnormalities like bicornuate uterus, unicornuate uterus, whether I proceed for correction of this? No, recommendation is said it does not improve the miscarriage rate. SR guideline recognize that septated uterus links to the first trimester pregnancy loss. Evidence. What is the evidence? Evidence for treatment of subsequent reduction in incidence of miscarriage is weak. What is the correction of uterine abnormalities like septated uterus, bicornuate uterus, cornuate uterus? What is the in summary? It is recommended that surgical treatment of septum has to be done in context of clinical trial. They said the septated among the uterine abnormalities, septated uterus removal of septum decreases the pregnancy loss rate, improve the pregnancy. But other type of abnormalities such as bicornuate uterus, unification of uterus, it does not improve the pregnancy rate. What is about leiomyoma? Should I go for removal of myoma before for increasing the pregnancy loss? Subserous myoma, no impact on pregnancy. But submucous myoma, it has to be removed. Otherwise, pregnancy loss cannot be prevented. But what is about intramural myoma? The evidence says removal, pregnancy rate is, success is uncertain. When I go for removal of intramural myoma? When it is more than 5 centimeters. RCUG guideline is silent about the myoma management, but SR guideline says the surgical removal of myoma is a controversial issue, but submucous myoma has to be removed. What is about uterine synechia? If there is a synechia, we should go for removal of correction of synechia, but correction of synechia before proceed for surgical correction of uterine adhesion, you have to be prepared. Surgery itself can promote more adhesion, so precaution must be taken in preoperative setting to minimize the further adhesion. If we proceed to adhesiolysis inside the uterus, but you can proceed to how to minimize the subsequent adhesion to increase the pregnancy rate, successful pregnancy. What is about endometrial polyp? It is a more common endometrial polyp, but if it is more than 1 centimeter, it has to be removed. Next one, cervical incompetence. This is also a promising, the cervical incompetence causes pregnancy loss. But cervical incompetence, pregnancy loss, how to assess the uterine factor abnormalities? What are the investigation I have to done? One is ultrasonography, 2-dimensional or 3-dimensional. 3-dimensional ultrasonography is better, but 2-dimensional ultrasonography is also best, but it has to be transvaginal ultrasonography. Second is sonohysterography, that means saline infusion sonography, more than saline infusion sonography, more accurate than hysterosalpingography for detection of intrauterine abnormality. To detect the septum and bicornuate uterus, saline infusion sonography is better than hysterosalpingography. And MRI is differentiate the septum from bicornuate or unicornuate uterus. It is a good investigation, but it is costly. Last one is hysteroscopy. It is a gold standard for diagnosis and treatment of intrauterine lesion, but it has to be reserved when other investigation is failed. But because it is an invasive and costly, but people are not agree to do an operative procedure. This is a picture of hysterosalpingography. There is a bicornuate uterus, and whether it needs to treatment for increasing the chance of pregnancy. What evidence says? I summarize this one. When submucous fibroid, hysteroscopic resection must. If hysteroscopic resection is not possible, you have to do by putting an incision on the uterus, but pregnancy rate is increased. Intramural myoma, either by laparoscopy or laparotomy, whatever it can be possible if its size is more than 5 cm. Septum may or may not need a treatment. Patient conceive and give a successful live birth. Polyp and synechium may or may not. And other Mullerian abnormality, no treatment, not to touch the uterus. What is about the cervical incompetency? Everybody give an idiopathic pregnancy loss, put a cervical encercles. But before proceed to cervical encercles, you have to be cautious about your mind, because cervical encercles has a surgical hazard and it also stimulates the uterus for abortion. For this reason, you have to serial cervical sonographic surveillance is necessary during the pregnancy to put on her empirical cervical circles. Next one, and only to be considered cervical circle when woman is likely to be benefited. What is the route? We are usually accustomed for transvaginal route. Transvaginal route for cervical circles. But somebody says it may be a transabdominal. When we proceed for transabdominal, when transcervical circles fail, or there is a short cervix and a scar in the cervix, but it is not usually practiced. Next common cause is immunological, not common, but there is an immunological cause for pregnancy loss. Why immunological? Fetus is not known to the mother, but it is genetically not identical. That's why immunological problem. And immunological problem is a two type. One is autoimmune, another is alloimmune. Autoimmune means this is the antibody toward the cell tissue and cell. What is this? SLE and antiphospholipid antibody. SLE is not so uncommon in our community, SLE. But young ladies are suffering from, more common is SLE. You have to think for SLE when the patient has a repeated pregnancy loss. Antiphospholipid antibody, it occupies a big group. And when there is a lot of test for antiphospholipid antibody. The anticardiolipin antibody, anti-lupus antibody, beta-2 glycoprotein, all are done in the Bangladesh. There are separate laboratories. But before going for this, you have to be criteria. One is clinical, another is laboratory. When clinical criteria means 2 pregnancy loss, more than 3, less than 10 weeks, fetus death after 10 weeks, and premature birth before 34 weeks of pregnancy, and severe PET and severe placental insufficiency. At that time, you have to be think this lady has a antiphospholipid antibody syndrome. It has to be confirmed by doing a laboratory test. There are several laboratory tests. and this antibody has to be lupus anticoagulant, anticardiolipin antibody, beta-2 glycoprotein antibody. All these tests, not a single time. It has to be again on 6 weeks apart.